welcome back to the HPL seminar. Thank you for joining us today. It is my pleasure to introduce today's speaker, Shadan Al-Saket. Shadan is, or actually I should say she was an honors student in the Muscle Strength and Power last year at the University of Calgary, and she just completed her BSc in biomechanics through the Faculty of Kinesiology. And I think you walked the stage on Monday. Yeah. Congratulations on that. So during her time here as an honors student, Shadan's research, supervised by Dr. Matt Jordan, was focused on the impact of injury on athletic performance. And outside the lab, Shadan has a passion for ice cream. Unlike me, she doesn't just enjoy eating it, she loves making it too. So with not one, but two ice cream makers, she says that she's always happy to dive into the science behind the perfect scoop. Today, however, she will be presenting her research titled Performance Ready, Contralateral Limb Detraining Clouds the Performance Benchmark in ACL Injured University Athletes. Thank you, Shadan.
Thanks, Dasha. No ice cream? No ice cream today. We're just gonna get right into it. We heard about ACLs from Zach a couple weeks ago and Nathan about a month before that, so we're just gonna dive into it. So first off, an ACL is a major stabilizing ligament in the knee, and it resists anterior translation as well as creates rotational stability, specifically in high-speed change of direction and cutting movements required for athletics. It is a severe traumatic knee injury when you tear your ACL or have any sort of injury to it. And it's usually accompanied by injury to other structures in the knee, and it's one of the biggest threats to an athletic career. Female adolescent age athletes are 4 to 6 times more likely to tear their ACL than their male counterparts. And once you tear your ACL, you're at a high risk of re-tear to that injured limb, but twice as high to the uninjured contralateral limb. So once an athlete tears their ACL, how do we let them know that they're ready to go back to sport? Historically, it was based on chronological time from injury. So right at 9 months, you were said, you're good to go, you're all done your rehab. Currently, there's been a push for functional and performance testing used in return to sport readiness. However, this performance testing doesn't really take into account biomechanics. Though it does take into account that the fact that return to sport is a continuum, it doesn't just happen over one day, and it can take up to 5 years to fully return to performance. The most common clinical test used is what you're seeing up here with the triple single leg hop for distance, where clinicians will measure the distance that you jump and say if you have 90% limb symmetry index between the two limbs, then you're good to go to fully return to sport. But even after return to sport clearance, athletes often still lack that mechanical power and mechanical strategies used that are required to perform these tests. Kotsafaki said it best when they said that measuring hop distance, or LSI, is not informative of movement quality nor recovery of knee function after ACL reconstruction. For example, in 2021, Kotsafaki explored the involvement of the knee in horizontal hops as well as vertical jumps in single leg movements, and found that the knee joint contributes minimally to propulsion in the horizontal hop for distance, possibly masking knee joint strength deficits when used in ACL return to sport, meaning that it's very poorly estimating how well an athlete is able to move. Another issue with current clinical return to sport testing is that the contralateral limb seems to detrain over the rehabilitation period. In 2018, I believe, Wellstan collected pre-surgery benchmarks of athletes and created an estimated pre-injury capacity benchmark. After surgery and 6 months after rehabilitation, athletes were compared to this EPIC score, which is what they called their estimated pre-injury capacity benchmark, and found that about 60% of patients who passed normative return to sport didn't pass when using the EPIC score. They also found that compared to the EPIC score, people who did not pass were more likely to risk subsequent injury. So how do we define an objective benchmark when that contralateral limb seems to be detraining over time? There are three options here: using the contralateral limb. The second one is to use a pre-injury baseline benchmark from the injured athlete, but the problem here is that the athlete did get injured, so how much can we trust that pre-injury benchmark? Another issue arises where it's not very accessible for all athletes at all levels to obtain a pre-injury baseline. The third possibility is using a healthy athlete completely outside the known realm of injury as a benchmark for return to sport. However, uninjured healthy athletes may present like they're injured, though we may not know that without doing mechanical testing. So how do we figure that out in a more simple way? I'm just going to pose a quick question here. Feel free to answer if you'd like. How many of you are acutely injured right now? By show of hands. Awesome. You can put your hands down. That was about 2 for the people in the front who couldn't turn around. Now, how many of you may not be acutely injured? You're healthy, you can move well, but you may have had a past injury that didn't rehab very well, not completely, and it still gives you aches and bothers you in various performance and day-to-day aspects. Show of hands. Well, if you look around, there's a lot more hands up. So we're going to explore this a little bit more. In 2016, Wilkerson created something called the Sport Fitness Index to try to understand how an athlete's previous injury history may affect their current mechanical properties. They use a retrospective and prospective analysis to put together 10 questions and validate it on uninjured NCAA Division I athletes. In the retrospective analysis, they took 4 well-validated questionnaires, such as the foot and ankle ability measure in sport, and they had a group of athletes fill out these questionnaires and then fill out a self-evaluated time lost from sport for their past sport season. They then took these answers from these 4 questionnaires, which accounted for about 80 questions, and they took the top 10 questions that seemed to delineate athletes who got injured in that previous sport season. Prospectively, they had another group of over 100 athletes fill out this questionnaire and found that athletes who reported time lost from sport in their upcoming sport season had lower SFI scores. SFI, after filling out the questionnaire, is scaled from 0 to 100. Any value below 60 was considered poor limb function, and any value of 86 or above was considered good limb function. Just wanted to emphasize here that these are all healthy athletes. So poor limb function doesn't mean that they're currently injured. It just means that they may be at higher risk for injury in the future. This was explored here in our lab with Zach, who you heard from a couple weeks ago, and he looked into the relationship between SFI scores and mechanical asymmetries. After this long testing battery that over 400 dynos athletes came in for, they filled out a psychosocial questionnaire. And part of that questionnaire asks about attitudes towards training, but more importantly, the Sport Fitness Index. Zach found that during the concentric phase of the counter movement jump. Athletes with poor perceived limb function had small but significantly higher between limb asymmetries than athletes who were considered good limb function. All of these athletes, having been uninjured healthy athletes, seem to show interlimb biomechanical asymmetries in these bilateral jump and strength tests. Today is we're going to talk about how I explored using the single leg counter movement jump and exploring how it may distinguish differences in jump mechanics. The single leg counter movement jump has been suggested to show capacities for mechanical function differently than the bilateral counter movement jump, as athletes may be able to compensate with one limb or the other in the bilateral counter movement jump. For example, here you're going to see an ACL injured athlete doing a single leg counter movement jump on their uninjured side. There are three general stages of a counter movement jump. The first one being the unloading stage, from the beginning of the counter movement jump down to the bottom of this trough. The second one being the braking phase, where they come to a stop from the bottom of the trough, close to the top of the first peak. And the last one being the propulsive phase up until they launch off the ground. This jump that you're seeing here is the same exact athlete jumping on their uninjured side. And as you can see, there is a stark difference in how they create force over the length of the counter movement jump. Specifically, here before the propulsive phase begins. So our group has done performance testing in ACL injured athletes with the goal of helping them return to sport. But we've only used traditional biomechanical analysis to do this. And looking at phase analysis, we see that we could probably get some more information out of these jumps if we looked at the entire force time waveform. Another way we can analyze these jumps, aside from traditional biomechanical analysis, is using something called statistical parametric mapping, which is another way to understand how people move. Statistical parametric mapping, or SPM, can identify differences in biomechanical strategies across a whole waveform. By using SPM, we can move beyond phase analysis and really understand how these athletes are creating force across the single leg force time curve. For example, SPM has been used in bilateral counter movement jumping in ACL injured athletes, comparing a pre-injury counter movement jump to a post-injury counter movement jump. Cassidy, who worked with our group in 2025, released this paper explaining that when comparing a pre-injury to a post-injury benchmark, athletes create less force post-injury consistently throughout the entire force time curve. And these differences were not seen when she did her discrete analysis. So the purpose of the study today and this talk is to examine the influence of perceived limb function on interlimb force time curves, asymmetries during single leg counter movement jumping in healthy university athletes, as well as ACL injured athletes using SPM. We'll also be comparing the single leg counter movement jump force time curve of ACL affected and unaffected limbs to a healthy matched control group, also using SPM. We hypothesized that the poor perceived limb function group would demonstrate increased interlimb deficiencies across the force time curve compared to the good perceived limb function group, and the healthy control group benchmark would unveil greater force time deficiencies in the ACL injured limb compared to the unaffected limb. Starting off with our control group, we had 464 athletes come in for a testing battery, including single and double leg jumps, as well as string tests. But today we'll just be talking about the single leg jumps. 58 of these athletes were in the good limb function group, while 129 of them were in the poor limb function group. The athletes in the fair limb function group were disregarded for the purposes of this study. We also had 20 ACL injured athletes, 11 of whom were female. We also used a dynamic time warping method to time standardize the force time curves, which aligns key characteristics in a force time curve and can decrease temporal variation. The characteristics that we aligned were the initiation of the counter movement jump right at the very beginning, the end of the braking phase, as well as takeoff. Well, the way we did this is we took the average phase length across the entire data set, and we individually normalized the eccentric phase and the concentric phase for each athlete, and then stitched it back together to get our force time curves. Starting with our healthy athlete population, taking a look at this table right here, we see that there aren't really differences in how these athletes perform during the counter movement jump, where female athletes in the good perceived function group, as well as female athletes in the poor perceived function group, have relatively similar jump metrics. Same thing for the male athletes. What really differentiates them here is their SFI scores. I'm going to break down this figure before pulling the rest of it up. This SPM figure shows time as a percentage on the x-axis and a continuous t-value on the y-axis. Any value that crosses either of these red thresholds is considered an area of statistical significance. On the bottom row, you'll see a regular force time curve normalized by body weight, force being on the y-axis, and time as a percentage also being on the x-axis. For our healthy control group with poor perceived limb function, we found that during the final 10% of the force time of the single leg force time curve, they created less force in their right limbs compared to their left limb. However, in the healthy control group with good perceived limb function, we found that their force time curve tracks pretty well across the duration of the single leg counter movement jump, and there were no differences between these groups. So our key finding here is that the evidence shows that there are small interlimb differences based on perceived limb function in the mechanical aspects of these single leg jumps. Next, we wanted to select a healthy control benchmark group out of this larger healthy control group. This healthy control benchmark used data from only the good perceived limb function group and ranked them by their jump height from top jumpers to worst jumpers. We then matched each ACL injured athlete by sex and sport to this healthy control group, and we called these matched controls the control plus group. In our healthy control group, we had 20 athletes, 11 of whom were female and 9 of whom were male. And then in our ACL injured group, we also had 20 athletes, 11 of whom were female, and 9 of whom were male. So what did we compare here? We compared the ACL injured limb to the ACL contralateral limb. We also compared the ACL injured limb to the control plus benchmark and the contralateral limb to the control plus benchmark. In this group, we found among our female athletes, there were significant differences in jump height, specifically between the ACL injured limbs and contralateral limb, but no difference when compared to the control plus group. For male athletes, we found no differences between the ACL injured limb and contralateral limb, but differences between each limb and the control plus group. Taking a look at the complete single leg counter movement jump waveform of these three comparisons, we found that when comparing the injured and the contralateral limb, in the final 8% of the jump, ACL injured limb consistently created less force than the uninjured limb. Now taking a look at the injured limb versus the control plus benchmark, we found, as expected, that the injured limb created less force during this time for a longer period of time that lasted about 15% of the concentric phase. And then when comparing the contralateral limb to the control plus benchmark right over here, we saw that the limb's force time curves didn't track very well. There was no significant difference, but by visual inspection, we saw that there could be something going on here, which is something we'd like to explore a little bit more. In conclusion, the control benchmark, which accounts for interlimb force production differences in healthy control athletes with low perceived limb function, seems to unveil greater force reduction in the ACL injured limb force time curves compared to the contralateral limb benchmark. It also seems to point to some sort of reduction in contralateral limb force production in the ACL injured group. However, there were no statistical significance here, and we believe it's due to some sort of variability. Future directions are gonna explore how ACL injury impacts eccentric control and the transition between eccentric and the concentric phases of the contralateral limb. We'd like to explore the relevance for reestablishing a better performance readiness benchmark for return to sport in these athletes, and hopefully address the problem of high rates of subsequent re-injury. Massive thank you to everyone in my lab for their help, everyone who was a sounding board, and thank you to everyone here to listen.
That was really good.
Thank you.
So any undergraduates out there that want to present in the seminar, please. You don't need that much data, 20 minutes of data. So fantastic, thank you for that. Okay, so bear with me. So it seems like the biggest differences between either the ACL injured in control or the ACL and contralateral happens not necessarily during this braking part of the jump where you're slowing down in the negative direction. It's happening predominantly when you're speeding up in the positive direction, which I'm gonna call concentric.
Yeah.
Not necessarily. Okay, so this is maybe a semantic argument, but we're talking about the inability to maybe produce as much force during this phase.
Mhm.
And so this is a semantic argument. But do you think it's really the magnitude of the force that a muscle can generate? Or do you really think that this is like a timing issue and an issue of the velocity of contraction? Because you can produce the exact same amount of force during that concentric phase. But if you create it sooner after that eccentric phase, the force curves are gonna superimpose there. And you're just gonna have a higher peak force during the concentric phase. I guess the question is, if they were just doing isometric contractions on a biodex, and you compared ACL versus non-ACL, would you expect differences in force production?
I don't know if I would necessarily expect differences in force production, but I would expect differences in rate of force development.
Yeah, so maybe this is more like, maybe what we should be talking about here is more like power. Rather than, I don't know, I'm just,
Yeah.
I'm throwing some stuff out. Anyways, food for thought. Then my other question was, where are the differences were there differences in mass between the poor performing groups and the good performing groups? Because there was maybe 5 to 10 kilograms between the average values.
There were not differences in body mass.
Okay.
Yeah.
Cause they, like, the means are pretty different,
The means are pretty different, which,
but probably a lot of variance.
yeah.
Okay.
And it is over 7 different sports, so you have a lot of different athletes put into each of these groups.
Okay, so, alright, well, that's a good question. So, were there differences in the sports that these different groups were participating? Not for the matching, you probably
Yeah.
matched it well, but for here, 7 different sports. Are the different sports equally distributed amongst the different groups?
I don't know, I can look into it and let you know.
Okay, other questions for Shadan? Alright, I'll ask one while we wait. So you said that you used SPM because now you're allowed to, you're able to look at differences across that time series compared to a phase analysis or a traditional analysis that you would do. So based on the SPM results, did you find the differences that you found in certain parts of the curve? Did they align with your expectations that you've seen based on earlier results of phase analyses, or was it something completely surprising where you found those results?
In the ACL group or the control group?
The ACS group.
I did expect there to be differences in the concentric phase for the ACL group. I also did actually expect there to be differences specifically in the ACL injured limb and comparing it to, during the eccentric phase, in either the comparison of the injured limb or the uninjured limb to the control benchmark, which we kind of saw here, but it didn't reach statistical significance. What I didn't expect was for these differences during the breaking phase. I'm not sure if Matt had a different expectation for what to see in these, but that's what I expected to happen.
And then I had one more question. For your females, you didn't find any difference between your groups and then when you were comparing them to the control plus benchmark, but you found that difference in the males. Is there anything that stood out for why there was a difference in one group and not the other?
Nothing really big stood out. What stood out to me here was if I look at the contralateral, if you look across the whole contralateral limb, as well as the whole control plus benchmark, there isn't a huge difference between those two performance metrics. But in the males, you can see a very stark difference between, for example, jump height is 16 centimeters in the contralateral limb, but it's 23 in the control plus benchmark. Which I thought was really interesting that we didn't see the same thing in our female athletes. So that would be something I'd be curious to look into a little bit more and kind of dive into the data on both sides, on this side as well as on the sport fitness index healthy control group.
Adam and then Nathan.
Nice presentation. Thank you for that. If you could go back to the SPM graphs. I like SPM too because you can look at the whole time series. But if we look at like where your areas of significance are, they kind of seem to line up right with the peaks of the data, of the force data.
Right here.
And if the argument around SPM is, oh, you can look at the whole time curve and time series and, we're not just forced to look at just the discrete peak values. Here, the areas of significance are the peak values. So in theory, you'd see the same difference. What's kind of what do you think of that?
I'm not quite sure. I find it really interesting that here we found differences using SPM that we didn't find in the previous study by Zach, where he compared SFI and looked at those mechanical asymmetries. I'm not too sure why, but I do find that they align kind of across the peak and it's not just at that one point. So you are taking into account a little bit more information than you would without SPM, which I think is really interesting. And kind of exploring that a little bit more.
Very cool. Yeah, cool. And then I have another question. So this is all in the like jump part, right? So people are leaving the ground at 5.100 here. I kind of always figured that ACLs were injured on like a landing or like a cutting maneuver. So why did you study like the jump rather than the landing part of the force?
That's a really good question. I'll try to answer it. I don't know how well I'll be able to. So when we are helping an athlete rehabilitate, return to sport, you're trying to get them to a certain level of like peak power and strength in that like injured limb as well as the uninjured limb. And since the hamstrings act as a synergist for the ACL, you want that to be as high as possible. I'm probably missing a few things here, but because the injury happens in landing, you still want to be strong in propulsion and throughout the whole phase pretty much, to kind of counteract that.
So this is still a good measurement of like the strength. Yeah.
Nathan, you had a question?
Yeah, you go back to the other table where you had this one. So the SFI scores in the ACL group, they seem to be spread a lot than kind of compared to the other, just the high group or the core group they showed before. So do you think if you had a larger sample size of ACL injured athletes, and you were to then kind of like further stratify by SFI score, you would kind of find something different? Like if you looked at ACL injured people with a high SFI score, you wouldn't see the same sort of SPM differences that you showed there?
I think so. I think it would also depend on how well that athlete rehabilitated, if that makes sense, and how, what's the word? And how much they adhere to that rehabilitation process. Especially, it really depends, like practitioner to practitioner, what you have your athletes doing. So I do think there would be a difference, especially because all of these were taken kind of right when they were cleared to return to sport.
Robin, quick question for like your SPM analysis based on that table. So you created like 3 groups. But what kind of SPM like t-test, I guess, did you do like paired or just normal t-test? Because some limbs are for the same person, but that control benchmark is from another person. But did you mix the kind of t-tests you've been doing?
So we actually use a paired t-test for all of them, which I found really interesting. Tanita is a statistician that helps our lab with various questions like this, and she suggested using a paired t-test both for the injured limb and contralateral limb comparison, as well as comparing them to the control plus benchmark, because the goal of the control plus benchmark is to consider this athlete as a comparable benchmark pretty much with like similar sport, similar history, similar training. And that's why we use the paired t-test for everyone.
And did you try to do a nano value for that? See if like there was like global differences between your 3 legs?
I did not, but I think I'd be curious to try that.
And second question, so I think comparing like these 3 groups based on the SFI score is interesting, but your SFI score is basically a continuum of values.
Mhm.
Did you try to do correlations with SPM?
I did not, but I'd be curious to see. I think Zach studied did correlations with SPM. Am I right?
We like still broke people up into similar categories, but looked at whether like across different tests, limb symmetry was correlated more or less if you have more SFI score, which is a good SFI score. The answer is more correlated across different tests in the core group. But to sort of like jump on that is that there's maybe some benefits to separating these out into 3 distinct groups being very good, because in that Wilkerson paper, he identifies these like statistical cutoff values that increase your risk of either passing or future treatment based on these cutoff values, and then we subsequent treatment categories as well.
Curious to see what it does for correlation with.
Yeah, it'd be really cool.
Thanks.
Yes.
And so what is your conclusion, Shadan? Is it, do you want to have, like, control? Or the contralateral could work for females, for example? And what's the data that supports these conclusions? Because in females, it didn't make a difference. Like the contralateral could work as well, if you compare to that.
Not necessarily. I would say the conclusion is showing that there is detraining in the contralateral limb that's masked by using the contralateral limb as a return to sport benchmark by up to twofold is the calculation I got. Because that lower force production lasts for twice as long and it's twice as high when you compare the injured limb to the contralateral limb compared to the injured limb to the control plus benchmark. So our conclusion is that, yes, we're agreeing with all the studies out there that say there's contralateral limb detraining, but we're also adding to it saying that by using a healthy match control athlete with good SFI, we may be better able to set like a benchmark that will support an athlete in their return to sport and hopefully reduce the risk of return of repair, though we didn't look into that prospectively.
It had something else, but it's not related, but it's, basically what Brent was talking about, the concentric versus the eccentric contractions. So, in my mind, they come from different structures in the muscle. So the concentric is the active myosin cross bridges, while the eccentric is the contraction, but then you have the active stretch. And so there is the tendon, there is the passive element that are contributing to that. So they might be affected differently with injury, and then they heal differently. So this is the way I see it.
I don't know
I'm not
much
sure if you
about
agree with
muscle
that.
physiology, to be quite honest. But that makes sense to me. I'm sure that we can look into it.
Thank you for that, Venus. From Venus's question, I was wondering, were all of your participants relatively in the same phase of their rehabilitation? Like, was it the same amount of time from their injury and from when they were cleared to return to sport?
It wouldn't have been the same amount of time from injury, but it would have been like the same amount of time from when they were cleared to return to sport. So all of these tests were done within less than 6 months from when they were cleared to return to sport from their
But when they were cleared for return to sport, could differ between athlete to athlete and then sport to sport as well, right? Or not?
it could.
So why I'm asking is because I'm wondering maybe part of why females didn't show such a big difference between their contralateral and the control plus benchmark. Could that be because they were maybe not as far after their return to play or from their injury that they had that strength deficit that you're mentioning in their contralateral limb versus the males being further away from that time point?
Can you reword that?
So kind of just wondering if the reason you're not seeing differences between the contralateral limb and the control plus benchmark in females, if that has anything to do with where in time they are in their recovery phase.
Okay, I see what you mean. I don't think it has much to do with where they are in time with their recovery phase, just because the expectation is for that contralateral limb benchmark, or sorry, the control plus benchmark to be much higher than it is. So all these athletes, when they were cleared for return to sport, were cleared based on like functional criteria, pretty much. So those single leg hops for distance, single leg jumps for height, things like that. So theoretically, they should be at that like level of function where they can move properly and move well. What shocked me more was that difference between the contralateral limb and control being so small. Then when you look at the male group, that difference isn't as small as it was, yeah.
Other questions for Shadan? Okay, if there aren't any, let's thank her for her talk.